Okay, we are on air. We are live. This is Module 8 for Nursing 511. My name is Lucas. I'll be leading the discussion. Other team members can introduce themselves.
My name is Meg. I'm another member of the committee.
I'm Lindsay. I'm also a member of the committee.
My name is Sam. I'm a nurse, and I am also a member of the committee.
Hi, my name is Lucina. I'm also a member of the committee.
Okay, so we are a nursing committee at Desert Regional Hospital, and we'll be going about a task today. And our task is to reduce hospital 30-day readmissions by implementing a remote data collection program on patients with CHF. The background is that hospitals don't get covered if they don't get covered by Medicare if patients are readmitted within 30 days. So if we can reduce readmissions, we're saving the hospital money, in addition to providing better home-based care for patients. So this remote data collection program we'll be implementing will be measuring weight, blood pressure, heart rate, and maybe some other vital signs of the patient. And we'll be discussing things like ethical issues surrounding this today. So currently, research shows that there's 48 states participating in sharing electronic health record data for purposes such as research. And the data can be collected from thousands of patients, and data can consist of things like vital signs, but it cannot consist of things that are called patient identifiers. So EHR that can be collected can have like blood pressure, heart rate in it, but it cannot have patient names. It can't have anything that can allow identification of the patient. However, there's been issues in the past that data can be so specific that even though there's no explicit patient identifiers, the specificity of the data can be traced back to the patient and allow identification. This is something we'll be talking about today. So in reality, the data is purportedly anonymous, but it's not always anonymous because it can be traced back to the patient sometimes. So let's start our discussion with the topic of ethical issues. I think the main ethical concern is that patients don't always give their consent for their information to be released. And even though it doesn't have the patient identifiers and it's supposedly just data, it can have implications. So the information, even though it's just vital signs, does get released, and that can be sold or used by the public for, say, research purposes. So I read in an article by Simpson in 2006 in the Journal of Nursing Informatics that information is not morally justifiable if it causes more harm. The information can be used for a lot of healthcare. And that can, what are some examples we could think
of? Hey, sorry, Lucas, I didn't catch the last 10-20 seconds of that. You were breaking out.
Okay, can you guys hear me now?
Now I can, yes. There was a little bit of a breakup.
Okay.
Okay, apologies for that. So I mentioned ethical issues. We were saying how there's some ethical issues surrounding this, and one of them is that patient information is supposed to be used for more good than harm. Okay. And the good is like research for healthcare settings, but of course there can be a lot of harm. So what are some examples of harm to patients from collecting data, and overall, do we think that patient data produces more good than harm?
I think one of the things to consider is the relationship of trust between the patient and the provider. I was reading by Peterson, DeMuro, Goodman, Kaplan in the Journal of Medical Informatics Association from an article in 2012. They really focused on the questions that patients have about confidentiality. And so they emphasize the responsibilities of the second party, so the responsibilities of health clinics And some of those responsibilities include not using information for reasons other than intended, and not making information available to unauthorized third parties. So that's something I think that needs to be considered when we're looking at those databases and collecting it from medical records.
Another point that Fairweather and Rogerson make in medical informatics in 2001 is that the principle of limitation of collection, so that the patient is the one that should have effective control of their data. And some reasons to kind of skirt that issue would be if it's an emergency situation and the patient is unconscious, or if it's an issue of overriding public interest, like communicable diseases. But in a case like this, where it's kind of for hospital financial benefits, doesn't really fall under those parameters, and it's really the patient should have consent for their information to be collected and analyzed before we proceed.
Now, do we need explicit consent for the information that we'll be utilizing? An article written by Korovitz, 2013, in the Journal of Internal Medicine says it's a little bit unclear whether explicit consent is required for the reuse of EHR information, which is what we would be doing, correct?
Yeah.
I believe so.
Okay. Well, we would certainly need to determine whether or not consent is required.
Okay, I have some information from one of the articles from the Department of Health and Human Services. It was just discussing the HIPAA privacy policy, and one of the topics that was discussed was permitted uses and disclosures. So I can just read point 2 is that a covered entity is permitted but not required to use and disclose protected health information without an individual's authorization. So it said that based on treatment, payment, and healthcare operations, as well as for public interest and benefit activities, that the covered entities shouldn't need authorization. Also, later on, I read, and this is also in our informatics book as well, from Anderson and Firth in 2015, in Chapter 6, it discussed authorization, and from what I understood, the covered entity must obtain the written consent, but that's only if it's not for treatment, payment, or healthcare operations. So for what we're doing, I believe that we wouldn't need their authorization just because we're not sharing that information versus, like, only for treatment purposes in order to help the patient. But since we are trying to limit readmins to decrease hospital costs, there might be a little bit of overlap there. If anyone else wants to touch upon that.
That's a good point.
I agree with you. And the U.S. Department of Health and Human Services, on their Health Information Technology page, they make the same point about being able to use patient information for research or public health or healthcare operations. And I feel like this kind of fits. It's like for the patient's own health benefits, could potentially be used for research. Heart failure really is a public health issue in this country. And then constant readmissions, it's affecting the operations of our hospital. Could fall under that.
So I think, yeah, like what you're saying, Meg, we just need to focus on more of the patient benefits versus, of course, it is great to reduce hospital costs and have Medicare and Medicaid pay for their initial stay, but if we can do better helping the patients in the long run, I think that would be best.
Yeah, Lindsay, I agree with that. I think something that we need to consider is some of the information that's provided about health information privacy on the U.S. Department of Health and Human Services website, where they talk about ways to actually de-identify information. So if it's information that needs to be spread, we need to ensure that that information is de-identified. And some ways that they talk about doing that is formal determination by a qualified statistician. So as long as we have somebody who's qualified to do that and they're using that information correctly and dispersing it correctly as well, I think we'll be okay. And then the specific removal of specific identifiers. So making sure that when we're sharing that information with any other entities that need to use it, that we do not have any personal information such as addresses, date of birth, social security numbers, etc.
I agree there. Let's see. Kushida et al. 2012, an article in Medical Care, and Red et al. 2015 in Perspectives in Health Information Management cite de-identification as a method to kind of circumvent the need for consent. Another option is what's called I'm going to have a hard time with this one. Anonymization. This is where a patient's chart is the link between the patient and the patient's chart in EHR system is irreversibly disconnected, I guess. That may not be the best option. I really think the de-identification is probably the better option there, but it's always nice to have options. That's what I'm saying.
The only issue
we're on the right. Go ahead.
Oh, sorry. Just that an issue for de-identification for us is the fact that we're going to be sending nanotechnology to patients that are at risk. So someone will have to have access to their information, to their actual identifiers. So we probably have to focus on just limiting who is going to have access to that actual identifying info, because someone is going to have to.
Agreed.
And then that goes back also to talking about the respect and relationship between the patients and us, about whether or not they feel that we violated, because they may not want to be part of the program, and they might. So that's something that we can talk about later as well.
Yeah, we do have the right priority here that all the information has to be anonymous or confidential. We can't be leaking out patient information, because in an article I read by Slater in 2002 in the Journal of Home Health Care Management Practice, they bring up the point that if this information is not rendered anonymous before it gets used, then harm will come to the patient in the form of the example of, say, insurance companies monitoring patients at the cellular level for like genetic issues and then denying them coverage or upping the cost of their care just because they have this technology in them and their information is not private. So we do have to focus on keeping this anonymous, yes. So one thing we have to face with this is if we're going to offer nanochips to our patients, we have to select the group that will benefit the most from this. And we're going to have to use EHRs to select the patient group and review patient data and select certain patients and provide better care to patients, which means patients receiving this nanotechnology will probably get better care than those who are not. So let's discuss some of the pros and cons of using electronic health records for selecting patients for this technology. One of the where am I here? One of the cons that I found, and this was in Fairweather et al. In 2001 in the Journal of Nursing Informatics, is that patients who know their data is being used and whose data is being distributed, they might be reluctant to report certain healthcare conditions to their provider. And this can jeopardize the patient-provider relationship and ultimately affect the quality of care that the provider gives to the patient because they may not have all the data they need. So in addition to this, what are some other cons or pros of using data from EHRs for selecting patients?
There's one con that you touched upon in terms of insurance, and just another article kind of agreed with that. Staggers, McCaskey, Brazelton, and Kennedy in Nursing Outlook in 2008. They talk about kind of evolving policies, and that with new nanotechnology, we don't know what will happen with insurance. That maybe how patients respond to the information they get from their nanotechnology will affect coverage for future treatments. So we're not sure right now like how things stand with how our patients will be affected in the future with their insurance coverage.
Yeah, I would agree with that point, Meg. There was an article by Peterson, DeMuro, Goodman, Kaplan in 2012 in the Journal of Medical Informatics. And they actually looked at a law case between Sorrell versus IMS Health. And they looked at what the pharmacological companies, what type of data they were able to get from practitioners. So one of the concerns is if there was issues with pharmacological companies getting doing what they call data mining, will the nanotechnology companies also be privy to this? And in that, is that going to incur a higher cost for the patients, the way that some medications end up costing more because there's not a generic available?
As far as a benefit to using the EHR system to select our participants, EHR system is very cost effective. It's already in place, so to collect the data, and the patients that we need, it would be a lot less expensive to do so. And cost is always kind of an issue.
I think that's a good point. I think another pro is that we could say EHRs are not only just available and cost efficient, but they're going to provide the widest range of data. We have access to tens of thousands of patients and all the data we need. And ultimately, having all that data is going to allow us to produce better results for this task and allow a better outcome through using the EHR.
Agreed. Let's see. Rasmussen, 2014, authored an article in Cardiovascular Translational Research. He cited the cost effectiveness of the EHR system, and then also it allows scalability. You can use large populations for with EHR systems, and the information can be reused and repurposed for other inquiries or questions.
Yeah, I think the reuse is a good point, especially in terms of research, because I know our focus right now is on reducing readmissions, but there hasn't been a lot of research on nanotechnology at this point. There was one study I found, Ong et al. In 2016, and they did a study on monitoring heart failure patients. They studied 1,437 patients comparing telemonitoring of blood pressure, heart rate, symptoms, and weight versus telemonitoring. And they didn't find any difference in readmission rate, but our results could be different, and then that would be more research added to the field.
I think another pro for having this connection between the electronic health records and the nanotechnology is the other way around. What kind of information is the nanotechnology going to provide into the electronic health record that can then be better used by our clinicians and our patients? Staggers et al. In 2008, they found that the public generally has a pretty high perception or idea, expectations of what nanotechnology can do to benefit their health.
I
read
agree
that
with Tina. There was an article, a study I found by Damani, Salvatore, Silverstein, Ivana, Boviak, Iodins, and Riccardi in 2015. It was called Influence of Socioeconomic Factors on Hospital Readmissions for Heart Failure and Acute Myocardial Infarction in Patients 65 years and older. So it's evidence from a systematic review. And it pretty much just discusses the percentage of readmission. So it's usually 25% readmissions within 30 days. That fact I found in Computers, Informatics, and Nursing. And that was online by Aldergram, Orso, Kaplan, Oliver, Oranchetti, and Regal in 2016. So that study go ahead and discusses the information on mobile platforms. So by using the nanotechnology and a mobile platform to remind the patients to take their medications, to weigh themselves, to check their blood pressure and their heart rate, are all important just for the physicians to be able to see that information and to decide if further interventions need to be done or if their medications need to be switched. The first article I mentioned about socioeconomic factors is that most people are able to have that technology, but the improvements were found at the conclusion that race and ethnicity and marital status highly affect readmission for heart failure and acute myocardial infarction. So I think it would be important to address the specific population and make sure that we have the right implementation as well as support for these patients.
Another role that's going to fall on us providers when this technology is used with the patients is we're going to have to better educate them. In a study by Staggers et al. In 2008, as Lucina mentioned just a minute ago, in the Journal of Nursing Outlook, they found that patients would do better with nanotechnology if they were better educated on their condition. And the reason was that often patients are the first to see the data produced by their nanotechnology, say through like a computer or an iPad, and patients who aren't educated to reading the numbers that come through the nanotechnology, they can be more prone or more apt to make bad choices in interpreting those numbers. So that same study recommended that that providers could maybe better educate their patients when they give them the nanotechnology, and also have better supports in place for using the technology and for interpreting the numbers and knowing who to contact if there is a number that the patient, say, doesn't like.
I think that's also our role as the nurse, too, to make sure that we have the time to educate throughout the whole hospital stay instead of just the last 5 minutes on discharge and pushing them out the door. So if we're able to, as a pro, if we were able to implement this in the beginning of their hospital stay, we could kind of walk them through it throughout, the couple days or however long they're in to hopefully ensure less readmission as well.
I would agree with that. And also, as a nurse, I think it's also our responsibility to remind the patients that they're not diagnosing themselves. So like you're talking about with that information, Lucas, that they get on their iPad or on their computer, I think also reminding them and educating them that they're not responsible for doing something about those numbers unless that's already been discussed. I think relying on that as a tool and teaching them that nanotechnology is a tool that their doctors are going to be able to use. And that's something that Staggers et al. In 2008 in the Nursing Outlook Journal, they also discuss how the clinicians, once they get that information, can kind of customize a treatment or an intervention. But I think, like you said, Lindsay, we really need to educate the patients the entire stay and not just the last few minutes, because it's a lot for patients as they're getting discharged to remember everything that we've told them.
Mm-hmm. I've also seen.
Okay, these are all good. Did you have something else, Lindsay?
Should I continue? Yeah, I was just
Sure.
going to say I've seen that in the hospital setting, in regards to just small things like diet, where we give the patient a low-salt diet, but then even though we know that they may not follow that diet at home, I've seen that the nurses don't always care because we know that they're going to go back to their old habits, which I understand, but I think we need to try to teach more or explain more healthy options, at least give them the information that they can use on their own to be successful, and let them know, how to proceed.
Okay, so this is good. So let's integrate this information a little bit, and let's put together an evidence-based plan here. One of the most important factors we said early on is that the data has to remain confidential, and it can't be used, or it has to remain anonymous, and it cannot be used against the patient in any way.
Lucas, you're freezing up for me again.
Same.
Same.
Within it.
Yeah, Lucas, we lost you for a little bit. Could you repeat the last point that you made? I think you're back.
Yeah, I'm still here. Can you hear me?
Yeah, we can hear you now, but you just might want to
Yeah.
repeat what you just said because you froze for a little bit.
Yeah, we're trying to put together an evidence-based plan now. So does anyone have, do we have like recommendations to contribute to an evidence-based plan for our task?
Yeah, Lucas, I actually looked at a study by Mang, Starr, Tomkovich, Syandra, Salick, Griffith in 2014 in the Journal of Population Health Management. They specifically designed a healthcare program where they used telemonitoring. So they didn't use nanotechnology, but they did use telemonitoring. And they saw a reduction in hospitalization and the cost of care. The study focused on heart failure specifically. And what they used is they use an interactive voice response system where with the telemonitoring, they were able to get data from the patient by telemonitoring, and then they were able to address the patient with specific questions about some of those heart failure signs and symptoms, such as shortness of breath, swelling, appetite change, etc. And what they used to integrate this information was they actually used a case manager. So I think if we could have a case manager who can serve as that liaison between the patients and whoever the healthcare provider is, I think that would eliminate some of the burden on our patients and on our healthcare providers.
Okay, this is an excellent key recommendation to use the liaison. Do we have anything else?
I agree with some of the points that were made before, specifically about patient education, but not only about like reading their results, but on the nanotechnology itself, because that same article by Staggers et al. In Nursing Outlook in 2008 kind of talked about the gap between the advancements in nanotechnology and patient knowledge and education about that nanotechnology, and up to 80% of consumers have heard very little about it and don't know a lot about the safety implications or the risks and benefits. So to thoroughly educate the patients that we find eligible for the nanotechnology on exactly what we're offering, what the risks and benefits are, and what they're getting themselves into.
Another recommendation to add to that, Meg, is
Good point.
giving patients access
Critically important.
to their electronic health records. So there was a study done by Vodka, Mejia, Laville, Ralston in 2013 in the Journal of Medical Internet Research, and they looked at over 3,000 primary care patients in 3 different facilities, And they offered patients the opportunity to have access to their electronic health record and to the notes that their doctors put from their visits. So this is something that we can incorporate and give them that confidence with as well. And specifically, they looked at their attitudes for privacy. So I kind of think it takes us back to making sure that the patients are comfortable with how data is being used and that we're not violating any HIPAA violations or making any HIPAA violations, sorry. And they didn't see a big change in their concern about privacy, but they did see that 99% of the participants would still want access to their electronic health records a year after the initial study was implemented. So I think that's an important piece for a recommendation, is to involve the patients, not just in that nanotechnology, but let them see the progress that is being made and how their healthcare providers are perceiving their progress or lack of progress.
I think that's a great point, Lucina. As I kind of mentioned earlier in those other two articles I read, it's more about educating, and if we can implement with the nanotechnology, maybe an app or something that's helpful, that way the doctors or the physicians and the patients can communicate, or just simple reminders for educating, such as, weighing yourself every day at the same time, or taking your medications, eating healthier. Those are just some suggestions that I found from Computers, Informatics, and Nursing. Aldergram et al. 2016, as well as working with certain communities that need more support. Using the case managers is a great option, just to get people more involved and to follow up with them as well. I also had another suggestion. If possible, after we are able to implement nanochips, to when patients are admitted into the hospital through the emergency department or through their physician, if we're able to ask them if they're wanting to be part of this new program that we're implementing, and the benefits. I wouldn't say there's really any risks for being a part of it, besides their information being used for the physician to help their care. I think that if we're able to ask them upon admission if they have congestive heart failure, if they'd like to maybe be implemented into this type of program, it would be beneficial. That way we can catch them at the beginning of admission instead of on their next readmin.
I like that idea. However, let's see. We're focusing on patients that have high readmission rates, right?
Yeah.
Okay. So we can certainly capture some of those patients in the ER, but we need to focus on the ones with the high readmittance rates.
I was just thinking, because since congestive heart failure has shown high readmissions, that if they have a past medical diagnosis of congestive heart failure, that we just go ahead and address that information potentially, just as a thought to reduce the readmissions. And of course, I do think it is beneficial, as you mentioned, Sam, that we do need to make sure that to address it with the patients that are coming in more frequently. Definitely.
Great point, Lindsay. Yeah, the high readmission rates for congestive heart failures. I mean, you could just pretty much just pick any almost any given CHF patient that comes into the ER. Good point.
Mm-hmm.
Yeah, I would agree with both of you, Sam and Lindsay. I think it's important to also educate the patients about what is the readmittance. I mean, most patients don't want to return to the hospital. They want to do what's healthy and they want to do what's right for them. So if we can educate them and help them adhere to their program, then that would be important. The study that I mentioned by Meng et al. In 2014, Population Health Management, where they included the telemonitoring, they actually saw a decrease of 44% in 30-day readmittance and a decrease by 38% in 60-day readmittance. So I think that information with using just telemonitoring, which isn't the newest type of technology, that there's a possibility that using that nanotechnology would in fact reduce readmittance. But I think, like you said, Lindsay, and Meg as well, educating our patients and letting them know that this could possibly keep them from readmittance. So it's not just benefit to the hospital and cost, but it also benefits the patients as well.
I agree, and I think I agree with your point, Lindsay. I think capturing all congestive heart failure patients in the beginning, it means that we have their consent to use their information whether or not they're a high readmission risk. So it just covers all the bases. We have their consent to begin with, and then if we find out later they're a high readmission risk, we don't have to worry about the ethical implications of using their information because we already have that consent to begin with.
Yeah, that's a good point, Meg. And the information that we keep from the CHF patients, some of that of course would go towards like the data collection, but a lot of that would just stay. It's very personal. It would stay anonymous, and we wouldn't have to worry about that being too widely distributed. We would use that for providing patient care, not necessarily just for research. So let's see. I made a list of the recommendations and conclusions we just went over, and I'll be presenting this before we do our task to whoever we need to. So we want to use like a liaison or a case manager and the providers. I think Lucina put that up, and she also said telemonitoring waste to have decreased readmission rates. So that's definitely something important that we'd like to utilize. Additionally, we said education, patient education about nanotechnology, lifestyle choices, general health benefits. That's our duty as a nurse, and that of course is evidence-based for improving patient outcomes and decreasing readmission as well. And with that goes patient support. We want to improve the patient support and give them all the resources that they need to maintain high quality of health and prevent readmission as well. And then finally, allowing them to access their own EHRs and see their own data to prevent conclusion and encourage transparency with the EHRs. I think that's the last point. Before we close, does anyone have anything else to add to the discussion? Okay. Well, I'm going to close now. Thank you, committee, for participating in our discussion, and this concludes our Google Plus Hangout. Have a good day.
Thank
Thank you.
Bye.